Good afternoon, and thank you for the opportunity to present this study. As stated, my name is Mark Dudash. I'm a general surgery resident from Geisinger Medical Center. Today I'll be discussing robotic esophagectomy. I have no disclosures. Esophagectomy is used to treat many benign and malignant conditions. There are multiple approaches, including transhiatal, Ivor-Lewis, and McCune, among others. These can be done through an open, totally minimally invasive, or a hybrid approach. These are technically challenging procedures with a high learning curve and high morbidity and mortality. Minimally invasive esophagectomy was proposed to reduce the high morbidity associated with open esophagectomy. We have data from 2 multi-center RCTs that suggest decreased pulmonary complications with minimally invasive esophagectomy. However, no difference has been noted in overall complications or mortality. Robotic MIE is a newer promising MIS modality for improving perioperative outcomes. The limited studies done thus far have shown equivalence to the thoracoscopic and laparoscopic approach. The best approach for esophagectomy is still a matter of debate. First, we want to define the trends over time in the usage of minimally invasive esophagectomy in comparison to open. We then wanted to look at differences in perioperative outcomes between open, laparoscopic, and robotic esophagectomy. We looked at differences in length of stay and total charges between the groups. This was a retrospective study done using the National Inpatient Sample from 2008 to 2015. Inclusion criteria were adult patients undergoing elective robotic, laparoscopic, or open esophagectomy with resections performed for malignant or benign disease. We excluded patients that did not have hospital charge data or mortality data reported. We looked at demographics and patient and hospital factors by approach. We examined trend as well as perioperative morbidity and mortality between approaches on both univariate and multivariate analysis. All statistical tests were considered significant with a p of less than 0.05, and all statistical models for multivariate were adjusted for variables with a p of less than 0.2 on univariate analysis. We included 6,415 patients in our study. 91% had open esophagectomy, 5% had laparoscopic esophagectomy, and 4% robotic. Demographics were comparable in terms of age, sex, race, primary payer, income, and hospital academic status. This chart is showing the trend in the use of minimally invasive esophagectomy, and it shows that robotic and laparoscopic esophagectomy have been increasing between the years of our study. Looking at trend in use of robotic versus laparoscopic esophagectomy, we see that in 2008, laparoscopic esophagectomy was the majority of minimally invasive esophagectomy. However, in 2013, robotic esophagectomy surpassed laparoscopic to become the most common minimally invasive modality. This table is showing demographics which were all significant on univariate. Of note, the open group had the highest risk of mortality and severity of illness at baseline. This is rated from 1 to 4, with 4 being the most severe and based on ICD coding. The majority of patients underwent esophagectomy at large hospitals and private and nonprofit hospitals. Overall complications were lowest in the robotic group at 26.6% and highest in the laparoscopic group at 38%. These findings were significant on both univariate and multivariate analysis. This is breaking down postoperative complications by category. Pulmonary complications were lowest in the robotic group at 10%. These findings were significant on both the univariate and multivariate analysis. No significant difference was noted in the rate of pulmonary complications between the open and laparoscopic groups on multivariate. Looking at GI complications, which includes anastomotic breakdown, we see that they were lowest in the robotic group at 1.6%. These findings were significant on both our univariate and multivariate analysis, and no difference was noted between the open and laparoscopic groups. Cardiovascular complications, which includes postoperative DVT, PE, MI, and stroke, were lowest in the open group compared to the laparoscopic and robotic. Our multivariate analysis showed no significant difference between the open and robotic groups, in terms of cardiovascular complications. However, they were significantly higher for the laparoscopic group compared to open. Procedural complications were lowest for the robotic group at 2%. These findings were significant on univariate and multivariate analysis. No difference was noted between the open and laparoscopic group on multivariate analysis. The remainder of complications by category were not significant on either univariate or multivariate. Looking at mortality, we see it's similarly low at 1.5% for both the laparoscopic and robotic groups on our univariate analysis. However, these findings were no longer significant on multivariate. Looking at median length of stay, we see that it was lowest in the robotic group but it was not significant, however, on multivariate analysis. Total charges were similarly low in the robotic and open groups at about $122,000. On multivariate analysis, we found that laparoscopic group had a significantly higher total charges, but the charges were equivalent between the open and robotic groups. In summary, the trend in MIE increased over fourfold during the course of our study. The trend in robotic-assisted surgery had been increasing, and it's become the dominant modality of MIE, accounting for 7.9% of procedures in 2014. Overall complications were lowest for the robotic-assisted esophagectomy compared to the laparoscopic and open procedures, and total charges were comparable between robotic and open esophagectomy and highest in the laparoscopic group. As with any study, we have limitations. This was a retrospective study using a national database. Unfortunately, no long-term outcomes were available. It only captured events which occurred during the original index admission for surgery, so we weren't able to account for readmissions or complications that occurred outside of the hospital. Again, data collection is based on ICD codes, and for patients who had resection for malignancy, we don't have any available data regarding pathologic stage and use of neoadjuvant therapy. In addition, total hospital charges may not reflect the true cost differences between approaches, and there was only a small number of MIE procedures compared with open in our study. In conclusion, we see that esophagectomy is shifting towards minimally invasive surgery, although open is still the vast majority of cases. When it comes to minimally invasive surgery, the robotic approach is now more common than the laparoscopic. Robotic esophagectomy seems to have a lower risk of overall complications compared to open, as well as lower pulmonary, GI, and procedural complications, and we found no real significant difference in charges between the open and robotic approaches. Any questions?